Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be doing another Kahoot, and we're going to be going over emergency and mass casualty nursing. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and press that thumbs up button now. Subscribe to my channel if you haven't done so already. And don't forget, I'm now offering next generation NCLEX review sessions, private tutoring sessions, and private consultation sessions. I also have audio lessons available on my website for the students who are currently in the program. So you're not studying for boards, but you're currently in the program and you're not doing too well and you have to do very, very well on your next exam. Well, I have lots of audio lessons available for you. All of that can be found on my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms, such as TikTok, Instagram, and Facebook. My handle's the same everywhere, Nexus Nursing. All right, guys, without any further ado, let's get started. Emergency and mass casualty nursing. First question. Your patient's admitted with carbon monoxide poisoning. Which action takes priority? Is it going to be to give oxygen at 100% by face mask? Are you going to request a psych consult stat? Are you going to start a gastric lavage stat? Or are you going to maintain the patient's body temperature? Which is going to be your priority nursing action in the patient who's been admitted with carbon monoxide poisoning? Very good. Oxygen, ABC, airway, breathing, circulation. You have to establish a clear and patent airway before the patient can breathe, right? And of course, circulation comes after that. So let's talk about this. In your bloodstream, remember I said A, B, C, airway comes first. Airway, breathing, circulation. Guess what? Oxygen is carried in the bloodstream. That's part of your circulatory system, right? But where exactly in the bloodstream? It's carried in the hemoglobin that's part of the RBC or red blood cell. When a patient has carbon monoxide poisoning, instead of the oxygen sticking to the hemoglobin, guess what sticks to the hemoglobin? You got it, the carbon monoxide. So when you give that patient oxygen, what you're doing is decreasing the life of what's it called? It's called something like carboxyhemoglobin. The carbon monoxide and the hemoglobin that's together is called something like carboxyhemoglobin. You're decreasing the half-life of that by, well, you're decreasing the half-life, right? So it's going to stay in their body much less amount of time. And so the patient's going to get more oxygen because remember, the oxygen is supposed to be sticking to the hemoglobin, not the carbon monoxide. So that's going to be the patient's first priority. A year ago, your patient was in a motor vehicle accident and they were an hour ago, sorry. They were thrown out of the car because of no seatbelt. Their vital signs are stable. They have an open fracture of the right tibia. What's going to be your priority? Is it going to be to address hemorrhage, infection, deformity, or shock? 1 hour ago, your patient was in an MVA. They were thrown out of the car because they weren't wearing a seatbelt. Their vital signs are stable. They have an open fracture of the right tibia. What is going to be your priority to address? Wow. Only 2 people chose infection. So I'm so happy you guys did this because that's giving me an opportunity to talk about this. And I get where you're coming from because there's been a fracture. We're going to be concerned about hemorrhage, yes, but let's go back to the situation where this patient wasn't wearing the seatbelt. Vital signs are what? Stable. Let me tell you something. If your patient's hemorrhaging, you know what you're going to see? You're going to see blood pressure go down. You're going to see heart rate go up. You're going to see respirations go up. You're going to see O2 sat go down. Vital signs are stable. The reason I put vital signs stable in there to let you know we're not going to be looking at hemorrhage because we checked the vitals, right? This patient has an open fracture. What does open fracture mean? Because you have an open fracture and a closed fracture. When you have a closed fracture, the bone is broken, but the skin has not been pierced, right? the bone is broken in the body. But when you have an open fracture, that bone, not only is it broken, it's exposed to the environment because it's pierced through that patient's skin. Remember, the skin is your first line of protection from infection. That's what we're going to be concerned about, guys. Infection. Okay? Someone said, won't temp go up because of infection? Okay, that's a good question. Won't the temp go up because of infection? Yes. Patient has an infection, the temperature is going to go up, but guess what? It takes time for that temperature to start to rise because of infection. Remember on the last video I did, I was talking to you guys about infection and how, for example, if a patient has, they had surgery, they had some type of invasive procedure, you're going to be concerned about hemorrhage, you're going to be concerned about a DVT or pulmonary embolism, and you're going to be concerned about infection. But when it comes to infection, those signs and symptoms of infection, we're not going to see it immediately. It takes a minute, right? It takes a couple, about past 12 hours before we start seeing elevation in temperature, before we start seeing increase in WBC, before a patient starts developing foul odor from the wound site or mucopurulent drainage. But the fact that you saw open fracture, right? You should have been thinking infection, especially since we got hemorrhage ruled out of the way because vital signs are stable. And again, if patient has infection, the temp's going to go up, but again, it's not going to go up immediately. I hope that answered your question. All right, next question. Your patient's admitted to the ER, they're in AFib, heart rate's 170. What medication are you going to give first? Are you going to give a beta blocker? Are you going to give heparin? Are you going to give oxygen? Or do you expect that patient to get cardioversion? Okay. So let's talk about this because only 7 of you guys chose the correct answer. Patients in AFib, heart rate's 170. What should we give first? And the thing is, guys, if this patient's heart rate is 170, what's really happening? That heart, instead of doing this, is just doing this. Are we seeing cardiac output? No. Right? We're not seeing cardiac output. The demand for oxygen has increased because the body's not getting the oxygen that's supposed to because cardiac output has decreased. So yes, that patient is going to get a beta blocker, that heart rate's 170, but our priority at the time right now is that oxygen that the tissues are not getting. The correct answer is oxygen, guys. Airway comes first. We have to make sure patient has established airway so they can breathe, right? And then after that, we worry about that circulation. Guys, the only time circulation comes first is when we're doing CPR. So why would we give a beta? And by the way, guys, you give a beta blocker to the person. It's not like that heart rate is that dysrhythmia is going to change in a second, right? So we're giving the patient a beta blocker. In the meantime, their tissues are still dying. Their tissues are still screaming out for help. That absolutely makes no sense. So the first thing we're going to give that patient is oxygen. Yes. After oxygen, yes, we expect to give the patient beta blocker. They may get heparin. Cardioversion, let me tell you something about cardioversion. Timing is very important because, let me see, it says your patient has admitted. Okay, so it doesn't tell us how long this patient's been in AFib. We don't know if they've been in AFib for less than 48 hours or more than 48 hours. And that makes a big difference because if that patient's been in AFib for more than 48 hours, we mess around and give that patient cardioversion. Guess what? That's enough to dislodge a clot for that clot to go directly to that patient's brain, right? So timing is very important when it comes to the cardioversion. Blanca says, why not heparin? Absolutely. We expect that patient to get Coumadin. We expect that patient to get heparin. We expect to do bridge therapy on this patient. But the point is, I can't speak. The question is asking first. That's not what we're going to do first. They will get heparin, though. They're going to get bridge therapy, but what I'm saying is that's not the priority, because we don't want that patient to develop more clots. Does that make sense? Okay, good. Oh, the pin to get into this Kahoot is 287-2478. 287-2478. You're welcome. All right, select all that applies. The same patient that was in AFib, right? That same patient with AFib has no idea how long they've had this rapid and irregular heart rate. What are the goals at this time? Select all that apply. I'm so sorry. I think I gave you one or two of the answers. Sorry about that. So what are we going to do? Are we going to prepare for cardioversion? Are we going to decrease cardiac output? Are we going to increase exercise intolerance? Are we going to keep ventricular rate less than 100 beats per minute? Are we going to prevent stroke? Are we going to prevent clot formation? Select all that apply. So it's definitely more than one answer. That same patient that we were talking about that's in AFib, they have no idea how long they've had this irregular rapid and heart rate. What are we going to focus on? Okay, let's talk about it. So the correct, let's go over one by one. Prepare for cardioversion. No, how did 24 of you guys still choose prepare for cardioversion when I just told you if it's been more than more than 48 hours that the patient's been in this this arrhythmia, we're not going to do cardioversion, because we are not trying to dislodge any clots and make that bad boy go to the patient's brain and we killed our patient or we caused some serious damage. In the situation, it says the patient has no idea how long they've had this irregular heart rate. We're not going to take that chance, so that's wrong. Next, decrease cardiac output. That's wrong. How do 24 of you guys choose decreased cardiac output? That is the whole problem with AFib. When the patient's heart rate is so high, instead of the heart doing this, guys, look at my hand, because I want you to see what my hand's doing. This is the heart. Instead of the heart doing this and pushing out